Hi, this is Brian Wormers recording a lecture for University of Sioux Falls Medical Surgical Nursing on preoperative nursing. So one of the learning objectives today will be to understand reasons for surgery, describe the assessment need of your clients, discuss the components of informed consent, understand the preparations patients have prior to surgery, identify risks of surgery and what can be done to minimize them, and then describe some surgical risk factors for older patients. Perioperative period begins when the patient is scheduled for surgery and ends when the patient is rolled back into the surgical suite. The nurse will function as an educator and advocate, promoter of health and safety. There are many reasons for surgery, including diagnostic, trying to figure out what's going on with a particular disorder, curative, so fixing something or repairing something, restorative, fixing patient's functional ability, palliative, relieving some symptoms but not necessarily curing it, and then cosmetic, alter or enhance personal appearance. So there are different urgencies and degree of risk within surgery. Some of the urgency is, so elective is a planned correction of a non-acute problem, so this is not a rush. There's urgent, which means that you need to do it, could be life-threatening if delayed, but it doesn't have to be done right now. And emergent, meaning that if it's not done right now, it could be life-threatening. Degree of risk, minor means little, major means great, and just kind of depends on the situation and the status of your patient. Extent of surgery, some of the key words. Simple is, mostly it's not something that's overly complex. Radical means an extensive surgery. And then minimally invasive is a term that's used for usually endoscopes. Collaborative management, so we'll work together with multiple different people, and the way that we want to do our assessments is looking at history and data collection, so kind of screening the patient for risk factors, and we can talk about that. So some of those risk factors can be the age that they are. Very young and very old have differences in their pathophysiology within their body places them at increased risk. Any drugs or substance use can alter the way that anesthesia affects them. Medical history, including cardiac and pulmonary histories as well as renal histories. So they might have difficulty adjusting to changes, they might have difficulty in ventilation and perfusion, as well as clearing any meds with renal. What meds do they take currently? When was the last time they ate or drank? Any previous procedures or anesthesia? And, specifically any complications. Malignant hypothermia is one of those big complications that we'll talk about here in a little bit. Other history, any blood donation, so we can talk about autologous blood transfusions. So are they expecting to get their own blood? They can get directed blood donation by a family member if they're a match. And then of course we're talking about discharge from even before the surgery begins. And that's very key because once you start getting some of the anesthetic drugs in, people don't remember things. And so teaching when they have medications on board can be very challenging. And so it's often better if you can do a lot of the discharge teaching before they receive those medications. And also we got to make sure that we're discharging into a home environment and in which they have self-care capabilities and they've got support for them. So physical assessment, so it's very important that we obtain a good baseline. It's crucial for inter-op and post-op because once they see the patient is in an altered state. And so they really are dependent on pre-op to do a good assessment. You need to focus on the problem areas identified in the history. All body systems are affected by surgical procedure though, so realize you have to do a very detailed and thorough assessment. Of course, if there's any abnormal findings prior to surgery, we do need to inform the surgeon and anesthesiology just to make it safe for that patient. Systems-wise, we talked about cardiovascular, respiratory, and renal, and this is some of the major concerns that we would have. So coronary artery disease or an MI before surgery, chest pain, hypertension, dysrhythmias, of course, are very concerning. Respiratory, any chronic respiratory problems, or COPD, is particular. Obstructive sleep apnea is another one. So, especially when they are undergoing general anesthesia. Smoking can increase the risk of this and decrease the oxygen carrying capacity. And then renal urinary, so do they have any kidney impairment, and that might impact the way that drugs are disposed of in their body, and so that might impact what medications we choose. Neurological, so determine their baseline. Realize that not everybody is fully functional. We have surgeries for people of all abilities, and so determining that baseline is crucial for especially like discharge, to see if they've gone back to baseline. Musculoskeletal, so any major things that we need to be aware of, especially if it comes to positioning during the operation. Nutritional status, so malnutrition, obesity, increased surgical risk, as well as like diabetes mellitus and things like that, that impacts the abilities to heal up after surgery. Of course, we want them to heal well. And then psychosocial, what kind of anxiety and coping ability and support systems do they have, and how can we help them with this? So we'll also do multiple labs before this. UA, looking for UTIs or anything like that. Also looking kind of at some of the urinary tests too to see kidney functions. So blood type cross match, especially if we're considering that they're going to need blood. CBC hemoglobin, just trying to track where their levels are initially and seeing how much they might lose during surgery. Clotting studies, just to be prepared. If they're on any medications that would increase this, then of course maybe prior to surgery we're going to have them stop that. Electrolyte levels, serum creatinine levels, so once again looking renal. A pregnancy test. I was going to say it's unfortunately not uncommon that people will deny that they could be pregnant and then on a pregnancy test they're positive. So, chest x-rays, EKGs, all those things are important. We do need to have informed consent before we do surgery. This is often for the surgery itself as well as for the anesthesia, and it might be for any specialized treatments that we are providing for them. So within this, the person that's doing the procedure has to get the consent before surgery. They need to tell them about the procedure, what are the pros, what are the cons, what are the alternatives. Let them know that it is optional or it is their choice. The nurse's role in this is not to sign the consent. It's just to verify that the patient was doing this of their own volition. So it means that it was not forced, not coerced, or anything like that. So we don't have to provide detailed information about it, just rather that this was the correct person that said it was, and that they got to sign. So they might sign with an X. That's still kind of old-fashioned. I haven't really seen that in practice ever, but legally they can do it. In emergency situations, telephone authorization is acceptable by those that might have power of attorney. In special situations, you might just have to do it, based on what's reasonable and prudent to save life and limb. Special permits might be required for some procedures, like I said, depending on if it's a new procedure, if it's been approved by FDA, etc., etc. Consent for anesthesia, consent for blood products, and then, of course, advanced directives are important to know the wishes of that patient. Oftentimes, these advanced directives, and if they've got like a DNR status or something like that, then that goes on pause until after the surgery is done. Implementing dietary restrictions, so oftentimes their NPO can't have anything to eat or drink at least 6 to 8 hours prior to. Sometimes the provider will just say midnight the night before. Time frame is controversial. We will, for younger kids, we'll let them eat more. I know that's more of a pediatric thing and a NICU thing. But sometimes we'll let them have clear fluids 2 hours prior to, just because their body needs that calories and hydration. The longer they go, though, it decreases their risk for aspiration. That's what we're worried about. So really stress adherence to this. Always ask them when the last time they ate was, especially in that pre-op period, because it's amazing how many people will drive through the drive-through on the way to surgery. Consult with providers about what medications they want. Like I said, if they've got anticoagulants, they might hold those for a little bit prior to surgery. There's certain meds that we want them to receive, also meds that we don't want them to receive, such as big boluses of insulin if they're not eating. And I think you can figure that with some of those out. Anxiety interventions, it is tough to have surgery, and it can be nerve-wracking. So try to distract them as best you can, comfort them as best you can, and try and support them through this. Patient preparation, so most of the time they've got to leave most of their clothing. You put it in a little bag and you send it with them, but they're wearing a gown just for access for the surgical sites. You want to leave valuables at home, or you lock them up. Be careful with leaving them with family. Make sure you document everything very, very well. Oftentimes we are taping rings that can't be removed, but even then, we really want to try and remove all jewelry and stuff like that. And better yet, if they can just leave that at home, it'd be the best thing for them. They do need to have an ID, because once they are sedated, then of course they can't talk. So asking patient name and ID or date of birth doesn't work. So you need an ID band on. You need to remove anything that can be removed: dentures, prosthetic devices, hearing aids, and like I said, document all these very, very well. Prior to the surgery, the surgeon will often sign the surgical site, especially if there's something that's a left or right, like a lower extremity. If there's only one of it, then you don't necessarily have to do this. Like there's one appendix, so you don't have to ask which one it is. But otherwise, if there's a left and a right, you need to document it well. And oftentimes the surgeon will have the patient put their initials on it. So piercings need to be removed. Some of the time, like if this is anything that will transmit electricity, so when they're using any electric cautery, it can cause burns to the patient. And so make sure that you ask about piercings. They're getting more and more common, and in places maybe that you won't necessarily see. So always ask. Skin preparation, so breakdown of skin increases risk for infection, so we try to mitigate this with antiseptic solution. We don't use a razor blade anymore because it causes microabrasions and micro cuts on the skin. So we use an electric clipper or a dilapidator to try and remove the hair, but we don't want to do the shaving. Prep for surgery depends on where the surgeon's at. So if it's abdominal, I mean, you're trying to find the area plus some. So just for covering that patient up and draping and getting them ready for surgery. Pre-op meds. Some of the studies are finding that if we get meds prior to surgery, that really helps them out. One of the studies was saying if we give pain meds and anti-anxiety meds prior to surgery, they use less overall. And so we're going to try and reduce anxiety, promote relaxation, and do these kind of things to try and get the patient as comfortable as possible. We might have to do a bowel prep depending on what kind of surgery this is. This can be go light, this could be lots of different things. But oftentimes we need to clear them out before they have surgery. So it's always good to ask about that. When did they start? When did they finish? What was their stools like towards the end? Prevention of complications of breathing exercises. So this is used in your incentive spirometry, coughing, turning, deep breathing, being aware of risk for DVT. So we're going to try and combat that with anti-embolism stocking, somatic compression devices, exercises, and getting them up as soon as possible. Patients at risk for venous thrombosis include obese patients, patients older than 40, history of cancer or decreased cardiac output, history of mobility issues, history of VTE, surprisingly enough, or PE, history of oral contraceptives, smoking, hip fractures, or total knee or hip. So I'm guessing you know most of these pneumatic devices and sequentials, but realize that they are very important after surgery. Preoperative chart review, so we want to make sure all the documentation is there. We want to make sure that all the scans and any labs are there and completed. And we're going to aggregate all that stuff and get all that together. We want to make sure that consents are signed and everything's completed. We want to make sure the patient is still willing to do this and wants to do this. Documenting any allergies, height, weight, all the basics. We do have national patient safety goals and informed consent, so one of those is ensuring the correct site is the one that we're going to operate on. So I know it sounds silly, but accidents have happened, and that's of course tragic. So we want to make sure that the patient and the surgeon are on the same page as to where we're going to do the surgery at. Licensed independent practitioner marks the site. Involve that patient as possible, like we talked about, having them put their initials on it. And then of course we're doing timeout procedures in multiple stages through this, but just making sure that everybody agrees. With older adults, they are at increased risk because of decreased cardiac output, peripheral circulation complications, vital sign capacity, blood oxygenations, as well as their renal function. So they might have increased blood pressure, decreased skin damage, infection, sensory deficits, so they might not feel anything that might be wrong, and some deformities related to osteoporosis or arthritis that can make positioning difficult as well as mobility difficult afterwards. Other considerations, do they have any allergies, chronic illnesses? Like I said before, nutrition is a key component for this. Any impaired self-care abilities, what support systems do they have afterwards. Realize that stress from surgery and anesthesia can be great on some of these patients, and that could really impact the way that they recover from surgery. Realize that mental status can change with this, especially in the acute period afterwards. That puts them at risk for lots of different things. And then of course fall risk is one of those things that they can be at risk for. So that concludes this presentation on preoperative patients. So if you have any questions, please contact me.